Thank you everyone for coming today. It's a privilege to lead this institute and to see so many faces from the people from the data management group. We will never forget Anne, by the way, guys. Anne Adonza, who we lost this year, or last year. To our international visitors, our friends who support our research. And I would really encourage all of our early career and mid-career researchers to go and find those people that are in the audience today. We have strong relationships with the people that come here because of two reasons. One, because of research excellence, and the other because they're truly good people who support early career researchers. And as Wayne has probably indicated, they're people who strive to make a difference and fit within the framework of the Mary MacKillop Institute for Health Research and the vision of Mary MacKillop herself. So my job today is simple. My job is to start the day by being the worst speaker. That's easy. It's only going to get better from here. I did at least note that we had a lot of exercise scientists speaking after this, so I knew I'd be better dressed than them at least. So that's my first job. But I thought I'd give you an overview of some of the research that my group has been doing with collaborations, and this is around chronic heart disease, and deliberately through the multidisciplinary lens, because this is all about team. None of the research I am showing you today can be done without a home team. So my own team, thank you for all the work you've done to support, and also through some key collaborations. And I'll be touching upon some collaborations with some of the visiting professors we've got here today, people that are part of our faculty. And the idea that only through teams can you really make a difference is something I think we need to take from this. This is the whole idea of bringing you together from junior to senior researchers, and also the people who support the research assistants, the data management. Only as a team are we able to make a difference. I simply don't think that the complex issues we're dealing with can be done individually. So if you want teamwork, then I hope that's what embodied through the MacKillop Institute. So let's start with a framework. And this is just a framework that my colleague here, Karen, will recognise, and Kimberly Keats, who's part of our team too, and our good friend Anna Mukumbi and PK, that put together a framework around the challenge of cardiovascular disease in Africa. But this, my friends, is the same framework that we can apply to Indigenous health and even to inequitable health within the Australian population, to recognise a simple thing. So you can see this pyramid. I won't turn around, it's pretty hard to turn around, but you can see a pyramid. And the pyramid is going downwards, saying there are external forces and internal forces around your health, from birth all the way till death. And the critical thing is that an individual is awash with these forces, from environmental, particularly in today's environment, political. Think about the anti-vaccination movement that's been spurred on by the Trump administration. So Trump has actually endorsed the man that came up with the spurious results around around vaccinations. So they're actually emboldened by this. And in some schools in Texas, you know that 40% of students are now not vaccinated. So they've reached the threshold for the re-emergence of measles and chickenpox and all the things that we eradicated. So there's political, obviously there's economical forces more than ever are challenging people's abilities to deal with health and make choices. Technological, then we have social cultural, of course, and then down to the individual. So I think it's important for us to frame it in that way. And tell me one person in this room who's actually got a handle on all of that, who is an environmental scientist, who is a political scientist, who is an economist, who understands technology completely, and sociocultural and individual. So if you want to understand health in that context, you need teams. So let's just take a quick point of how you might characterize a particular health threat within a population, and let's take chronic heart failure. Chronic heart failure is close to my heart, forgive the pun, but I haven't got it yet. If I went up the stairs, I get acute heart failure, but I haven't got a chronic heart failure yet. This is some wonderful imagery provided by Sarah Booley, one of our group, and Lei Chen, looking at how many people do we think have heart failure in Australia, and it's over 500,000 people actually have heart failure, with over 150,000 admissions. It costs more than $3 billion, and over 10 years we'll have probably an extra 150,000 cases. So this is not going away. Those figures look quite striking, but that's on a whole population level. But as you dig down, if you're in Melbourne, in actual fact, we're probably average. While you're in this part of Australia, the number of cases of heart failure is probably equivalent to what it is for all of Australia. So in other words, we sit in the middle of that distribution. However, Graham Maguire will certainly know this, who's Professor Graham Maguire here, that if you're in the Northern Territory, you're 15% more likely the number of cases is greater. In actual fact, we submitted to the European Heart, I think, meeting an abstract that actually suggested that in the Northern Territory and Central Australia, the cases, the burden of heart failure is equivalent to a first world country. In other words, to what we see in Africa. And what do I mean by that? I mean that the people that are affected by it are in the earlier age, so they're about 20 years younger, and the rates are higher. So there's actually quite a disparity, and there's some really nice work, hopefully going to be published in the European Journal of Heart Failure, showing that the population rate in the Indigenous, even to the non-Indigenous population in Central Australia, is really marked. And that does show those forces I was talking about that divide us. So we're not equal in terms of our cardiovascular health, and heart failure is a classic example that you can see that signal. There's another conundrum here, that heart failure, which is a syndrome affecting the whole of the body and the heart, is in actual fact inexorably linked to a number of other diseases and conditions. So we've actually identified 10 critical conditions that influence someone's health if you have heart failure. And I can give you a living, breathing example of that from a conversation I had with a gentleman last night. So we're finishing up a heart failure trial, someone we'd lost contact with, someone who'd actually rejected team management, and I'm going to show you the effect of team management soon. But he said, no, I don't need you. But I was speaking to him, I actually caught him in North Queensland. He was on a caravan tour with his wife. And he said to me, Simon, he said, since I've been hospitalised with this terrible condition, heart failure, I just can't get right. He said, I've been back into hospital with atrial fibrillation, and atrial fibrillation arrhythmias at the top of the pyramid there is there. He also told me that they had trouble with his treating him with diuretics because he's got kidney failure, that's renal impairment. He said, I'm having trouble sleeping. You can see sleeps up there. He said, I have had pneumonia, respiratory disease. So to put this into context, he'd been in hospital 5 times since we'd actually contacted him. And he said, my quality of life is terrible. And the really disturbing thing to me was the fact he didn't realise that it was a nexus between his heart and his organs. He didn't understand what was happening to him, because obviously he had decided that our team wasn't giving what he wanted. So we'd failed him in actual fact. So I had that conversation. The good thing, he was still alive, okay, because heart failure does kill you, but his quality of life, he said to me, I'm not quite sure that I want to be alive, even though he's on holiday in Queensland. He'd seen his GP 5 times, a locum GP up in Queensland, and we talked about the strategy that maybe when he got back to Sydney, how he could cope with that. But this is the reality. Heart failure itself is inexorably linked to a number of other conditions, and you can see by those dotted lines, it means they're very complex. And these patients, unfortunately, are getting more and more complex. Does this have an impact on outcomes? Well, it certainly does. So this is a Venn diagram of some of the most common things I mentioned: respiratory disease, atrial fibrillation, a chaotic heartbeat, with diabetes, obesity, remembering we're getting more and more of that in the community, with renal impairment, so your kidneys fail with a failing heart, and with cognitive impairment. And if you can just see in the middle, I'm going to turn around. Just here around mortality at 30 days, When you have atrial fibrillation with heart failure, respiratory disease, and cognitive impairment, 18% of patients will have died within 30 days. That's an amazing statistic. 1 in 5 are dead within 30 days of a hospitalization where they've received expert care and they've been discharged alive. So it shows to you that certain clusters of multimorbidity in heart failure are very malignant. And this is our challenge, because to date, we've been dealing with people with less complex conditions. So I'm taking you on a journey here. So let's go from the individual to the environment. So these are work we've been working on in seasonal variations in cardiovascular disease. And this I can relate to the gentleman I spoke about last night. He told me that they actually gone up to Queensland to get away from the cold, so he got away from winter, where we see a lot of heart failure hospitalizations. But he told me that every time he goes to somewhere hot and humid, he actually gets a respiratory disease and feels unwell. And so the environment itself, seasonal variations, is an amazing phenomenon that in actual fact guidelines and our management ignore completely. So here's how it goes. This is a sort of model that we've hopefully publishing with a Nature Reviews cardiology paper on seasonal variations. But it shows that in actual fact the environment itself has an impact both from cold snaps and warm snaps, if you like, heat waves. The amazing thing is this, and this is sort of showing you the physiological response. There's a whole range of physiological response. But for when there's a cold snap, when a cold snap comes through, and you guys here in Melbourne, remember we had a particularly cold snap this winter, about 5 to 10 days later, you get a cluster of cardiovascular events, of myocardial infarction, of sudden cardiac deaths. And it may well be linked to people developing flu and having the colds, but it's obviously probably a lag effect of about 5 to 10 days. On the other hand, when there's a heat wave and you're affected by extreme heat, it appears that you seem to have an immediate cardiovascular response. And that does make some sense physiologically. But if you map this out from an epidemiological point of view, so this is a model of what the interaction between the environment and the individual, you can see around the globe, and this is summarizing some of the data showing that up to, you can have about a 1.4-fold increased risk of having a myocardial infarction or a stroke or just general cardiovascular disease when exposed to seasons that change. And with, as you can see around on this graph, sorry, I'll just go back. As you can see with these peaks, we generally tend to get a winter peak, so that's a winter peak. And Australia, being a warm, temperate environment, still has seasonal variations. And here's the paradox for you guys who are from Norway. So when you live in a really cold climate, there's probably a cold adaptation. And in actual fact, you have less seasonality than you do in a warmer climate. And it's probably to do with a very complex, and this is why I showed you the model, a very complex interaction between the environment, behavioral response, and in terms of a physiological response. So the things you do, so once again, if you think seasonality is a classic example where if you had an intervention, and we do have an intervention, it's multifactorial, and it goes all the way from the controlling environment to controlling things like vaccination to behavioral response. So in other words, you need a team that understands all of those things to actually make a difference in seasonality. But seasonality is a key thing for us, and I want to use that, by the way, as one of the research themes I think that could bind the whole of our institute together, because I think if we want to really tackle from an ecological to physiological, understand it, and publish a paper in Nature, John Hawley, saying unraveling seasonality in cardiovascular health and disease, we actually need a team approach to that. So I'll be having discussions with a whole pile of you guys, and it's even from an epidemiological point of view as well. Okay, so where are we going with this? So heart disease, complex interaction. I just want to mention some of the work that we've been working on, and my good colleague Tina Yars will recognise this, about the actual treatment of heart failure itself, which I've mentioned to you. And I hope you recognise this one, Tini. a group of us got together a while ago and said, well, what works in chronic care of the management of heart failure? So a whole group, you could call this the mafia if you like. And the reason why I've sort of put this up is there's myself in there, so apologies for that, some self-citation, apologies. Tini Asma is mentioned there. Barbara Regal at the bottom there, she is one of our visiting professors as well. And there is Blue, the UK you can see here. In actual fact, the other person involved in there is Professor John McMurray, who's in the process of joining us as a visiting professor. So in actual fact, there's quite a, if you want to call it the ACU, MacKillop Mafia was involved in this as well. But essentially what we looked at was all our trials. These were seminal trials trying to work out whether team management of heart failure, that's doctors, nurses, approaching an organised care, what it works best to help people like the man I told you about who's got heart failure and is debilitated. Well, what it showed you, and you can see this stepwise approach here, that you can get some impact relative to usual care up here in terms of readmissions and the actual readmissions and days of readmissions. You get some impact if you've got someone on the end of the telephone, okay? So one person working away. You can also, in the blue bar, get some impact reducing readmissions, and that's improving health if you have a single expert and in person, so face to face. But in the red, the best outcome is when you have people working in teams and in person with the patient. In other words, working with the patient in teamwork. I hope you're getting my theme already, that you need teams, right? Not whether it's from research to health, you need teams, you get the best outcomes. And if you look at the array of things you can do in heart failure, in terms of this describing the characteristic components, there's a long list of things that is beyond the realm of a single person to deal with. And if I could sort of characterize this, and some people, apologies if you've seen this before, but dedicated disease management programs can be applied in different ways. You can do home visits, specialist clinics, you can do telemonitoring, or you can even go to basics with telephone care. But regardless of that, there are key things that we know work in heart failure. And our challenge really is how to put those pieces together in the best possible way to make the best possible difference. And we've made some progress in that, and Tini has been particularly proactive in that area. I just want to show you the results of the WITCH trial, which was a multi-centre randomised control trial undertaken by us, just to give you that it was all above board, strict criteria, minimum follow-up 3 years. And we looked at the difference between a clinic-based approach and a home-based intervention approach. So this is face-to-face, but in people's homes, so actually working more closely with the patient, so not asking them to come to us, but us going to them. And what we were able to demonstrate was a clear difference in hospital stay. So in a group of patients with about 280 patients, 140 in each group, we had over 1,000 days less in the home-based intervention group. More importantly, we were able to demonstrate a clear difference. And this is really critical. This happens all when we apply a home-based intervention, starts at 7 to 14 days. If I could magnify this spot here, I'd be able to show you up to about 10 days, the mortality is exactly the same for both groups. And then when you apply a home visit, remarkably it springs open. And it actually lasts all the way through with prolonged follow-up that the home-based intervention appears to convey a survival benefit in patients with heart failure. And in actual fact, so allocation is independently of home visits and home-based intervention. Teamwork in person works better than in clinic. And the numbers needed to avert 1 death is actually 6, which is quite remarkable in a health context. But it's not all, so please don't get me saying, well, haha, we solved the puzzle here, because that's not quite right. And I want to show you some other data. So we recently published in Circulation a composite analysis of home-based intervention across the whole spectrum of heart disease, from people with a simple diagnosis to really complex, like heart failure and atrial fibrillation. And just to show you how we put it all together, 3 trials. There was the safety trial, which was published in The Lancet, the NIL-CHF trial that was published in the European Journal of Heart Failure, and from the WITCH trial that I just showed you, published in Journal of the American College of Cardiology. They were very similar, and we were able to put them together. And essentially, we were able to show that home-based intervention across the spectrum of heart disease was associated with a 44% relative risk reduction of dying. And here's the absolute mortality. You can see here, not quite as clean now in patients with a range, so it took a while, but there was a clear difference in mortality in favour of home-based intervention. And the question was, why aren't we seeing as clean survival differences in this group? And we actually did some further analyses, and this is critical here, because this is, I think, one of the first times where we're able to demonstrate that a particular strategy that works overall for positive benefits in survival actually conveys worse survival for certain groups. Okay, so we were prepared to actually, I think, challenge the current paradigm that disease management programs are benign. If you look at all the hospital avoidance programs and all of the healthcare providers, someone comes up with a nice idea for contacting a patient, they'll fund it. There's billions wasted on these programs. But I think we're brave enough to say, well, when we examined our particular home-based intervention within it, if you were young and had a pretty good morbidity, so in other words, not many, so this is the Charlson Index of Comorbidity. This is about the number of conditions other than the heart disease that we've got. In actual fact, you probably were better off with a clinic-based intervention, us not going visiting you in the home. Now that's contra to what I said about the Which trial that said, well look, home visits work better than clinic, right? And at the same time, at the other end of the spectrum, at this point here, when people become really, really sick, we probably should leave them alone. We probably should be arranging palliative care. And the reason for this is, to me, is very clear, is because there is a sweet spot at where you've got chronic disease, we can make a difference with what we're doing with our current strategy here, right? But we actually worked out, if you looked at the home-based intervention, it's best reserved for people aged 59 to 81. Regardless of which trial and which heart disease you have, which form of heart disease, which is interesting. And survival was best for about 59% of our patients, 63 in the safety, which was an atrial fibrillation trial, and the NIL-CHF, which was in an earlier trial. In other words, you'd be really happy if you're that 65% right in that cohort, but you wouldn't really be happy with the 1/3 that said, look, we're offering you this fantastic idea of disease management, but in actual fact, we're exposing you to increased risk of death because of what we're doing. So it really does show that these disease management programs are extremely powerful. And I want to come back, really, and sorry, the ultimate multimorbidity is 4 to 8 concurrent diagnoses. And the reason why I want to sort of wrap that up is because we're dealing with complex patient populations. And just as an example, we hope to soon report on what's called the Central Australia Heart Protection Study. And the Central Australia Heart Protection Study, remember I talked about the Northern Territory and the high risk of heart disease? We've actually done a trial now of an outreach, culturally sensitive, family-centred intervention in Central Australia. And we've already proven in Central Australia that the number of risk factors within an Aboriginal community is enormous. And so here's Alice Spring, the top end of Central Australia, travelling up. And we've got Glenys here, so you know more than I do, Glenys. This really is a tough patient cohort. My worry when we did this trial is whether or not we were dealing with the same scenario where we're trying to be good intentioned and maybe we do the wrong thing. In other words, we actually make it worse. So we mess with it. I'm actually confident now that we've actually got survival benefit. I think we've got positive trial results from this, but it does show that we have to be really rigorous in how we apply the type of programs we are. And this is interesting. We've just been working on this thing called the close model. I'm calling it the close model now. But we analysed data from our WICH-2 trial, which is the next iteration of the WICH investigators, which is looking at more intensive management of heart failure versus a simplified version. And what we've been looking at is saying, well, can we actually avoid visiting people in the home? Are there people we can just apply simple things to? And this is just to show you, this model shows that when we broke up people, whether or not they lived in regional or rural Australia versus metro, then in actual fact, we think there is a good way of applying a combination of the hospital clinic care to structured telephone support or home visits. But the critical thing is, You may say, if someone lives, for example, 30 metres away from the hospital, well then maybe they should just get managed by a hospital or clinic. But in actual fact, they have more barriers to care. If they're really sick and can't get out the door, that hospital may as well be 100 miles away. On the other hand, there's some of our patients who live rural and regional who are completely independent. They can rely on technology. We don't have to go and visit them. In other words, what we're trying to do now is suit our management programs to suit the individual. In other words, so to be smarter. And the reason we're being smarter about it is because if we don't, we'll probably increase their risk of dying. So this is critical. And bringing this all together is a new NHMRC application, when in actual fact is combining a lot of what I've told you, is we've now just applying to the NHMRC, it's coming to you soon, Wayne, but initially, basically what we're doing is we're now looking at a group of 600 patients, hopefully, with collaborators with Maja-Lisa in Lokken in Norway, in the Arctic University at Tromsø. We're actually going to try, hopefully, work out a management program that's made up of home visits, some smart devices, some rapid access clinics and structured telephone support, also with some seasonal variation program to prevent that, to do a composite, very complicated, if you ask me, complicated intervention, but matched to the individual to actually try and deal with multimorbidity in a positive way. In other words, to try to avoid the gaps that we've got to. So that's one trial to keep an eye out on. Hopefully if you come back in a couple of years' time, A, we've been funded, and B, it worked. Because I'm still not quite sure if it worked, but that's where we're heading. Once again though, it requires a team to do this. So we've got very complicated intervention now because our patients are becoming very more complicated. And hopefully Karen and Olivia, so we had Olivia Britton with us this week working on this particular baby, is what's called the Panacea Heart Failure Trial, which is actually applying disease management, heart failure management, but in the African context. And so we've got plans very well established to do a trial crossing from, I'm not going to even try to say the name of the hospital in South Africa, I always get into trouble for that, but for the Victoria Hospital in Cape Town, I do that very well, but with our friends in Mozambique, also in Cameroon, and up into Nigeria, we're undertaking, hopefully, the Panacea trial, which is a little bit more simpler. This is back to patients who are younger, with less morbidity, but our heart failure management program adapted to the African context. And we've been shortlisted for a Wellcome Trust application, and fingers crossed, Karen, with cross thumbs for getting that over the line, because this is a really important program. And I just wanted to mention this thing because we've actually got the support of people like Tini Yasma to help us with developing a curricula for heart failure nurses in the African context to actually build up a coterie, and also with Barbara Regal. So we're really lucky with the international connections we have. All right, so that's almost enough from me, but I always talk about Africa to people and they say, is it really tough going over there? It's terrible. The conditions, oh no, this is where Karen lives actually, by the way. This is Camps Bay in Joburg, in Cape Town. As you can see, it's not so bad. So please don't feel too sorry for me, and John, you know this, don't feel too sorry, but I can guarantee you that the places going to be working with the Panacea Heart Failure Trial aren't going to be as salubrious. And it always amazed me. South Africa is a classic example of one of those that really, you get some really rich people and you get some really poor. So the disparity's there. And that's why we like working there, because it is such a wonderful place to visit and to work with, but the challenges are enormous.